Your heart attack did not begin in your chest. It began years earlier, quietly, in your legs, in your feet, in the small vessels and the skin and the nerves of your lower extremities, where the first evidence of the systemic vascular disease that would eventually reach your coronary arteries was already present, already visible, already communicating through 12 specific signs that most people walk past a mirror without reading. Heart disease kills more people than any other condition on earth. And the cruelest part of that statistic is this: the warning signs were almost always there. In the legs, in the feet, months before the chest pain, years before the event. Today I am going to teach you to read those signs, all 12 of them, clearly, precisely, with the clinical knowledge that allows you to know, not fear, but know, whether what you are seeing in your legs right now deserves an urgent phone call to your physician or a calm, informed conversation at your next appointment. This is the video that changes how you look at your own body. In this video, I'm going to walk you through all 12 warning signs in the legs and feet that the clinical research has linked to serious cardiovascular risk. For each sign, I'll explain the precise biological mechanism connecting it to heart health, reference the peer-reviewed studies that establish that connection, and tell you clearly what level of medical urgency each sign warrants. We are talking about signs linked in published research to a threefold increased risk of heart attack, signs that predict cardiovascular events up to 5 years before they occur, and signs that, identified and acted upon, completely change the clinical trajectory. 12 signs, clear mechanisms, honest urgency guidance. Let's begin. Sign number 1, the cramping code, claudication in the calves, thighs, or buttocks. Claudication, pain, cramping or aching in the leg muscles that appears predictably during walking and resolves within minutes of rest, is the classic presenting symptom of peripheral arterial disease. It is the leg muscle's equivalent of angina, the chest pain that occurs when the heart muscle is exertion-starved of blood. When the femoral or popliteal arteries are partially occluded by atherosclerotic plaque, resting blood flow is sufficient for the leg muscles at rest. But with exertion of walking, the muscle's demand for oxygen exceeds what the narrowed artery can deliver. The ischemic muscle generates lactic acid. Pain begins. Rest restores the supply-demand balance. The pain resolves. A study from the New England Journal of Medicine found that claudication was associated with a threefold increased risk of coronary artery disease events, confirming that the arterial disease causing leg symptoms is systematically present in the coronary circulation simultaneously. If you have pain in your calf, thigh, or buttock that appears consistently after a predictable distance of walking and resolves with rest, this is not a muscle problem. This is a blood flow problem. It requires an ankle brachial index test and a cardiovascular evaluation. Do not wait for your next scheduled appointment. Call your doctor this week. Sign number 2, the skin thinning tell, hair loss and shiny skin on the lower legs. This sign is subtle, quiet, and almost universally overlooked. But it is one of the most specific physical examination findings in peripheral arterial disease assessment. When chronic arterial insufficiency reduces blood flow to the lower legs, the skin and its appendages, hair follicles, sebaceous glands, receive inadequate oxygen and nutrients. Hair follicles are among the most metabolically demanding skin structures. They are first to fail under chronic ischemia. The result, progressive hair loss on the lower leg and dorsum of the foot, the top of the foot, combined with a thinning, shiny quality to the overlying skin that reflects the loss of the dermal layer's normal thickness and texture. A study in the Journal of Vascular Surgery found that hair loss on the lower extremities and skin atrophy were independently associated with documented PAD on imaging studies. with sensitivity and specificity sufficient to make them clinically meaningful physical examination findings. Look at your lower legs and the top of your feet right now. Is the skin thin and shiny? Are there areas of reduced or absent hair that were previously present? These are quiet signs, but they are meaningful ones. Mention them at your next appointment. Sign number 3, the temperature asymmetry. One foot significantly cooler than the other. Temperature asymmetry between the 2 feet, one measurably cooler than the other, is one of the most clinically specific signs of unilateral arterial obstruction in vascular medicine. When one leg's arterial supply is more compromised than the other, due to unequal plaque burden in the femoral or popliteal artery, the distal tissue of that leg runs cooler. The body has not failed to warm the room. It has failed to deliver adequate blood flow to one extremity specifically. A study from the European Journal of Vascular and Endovascular Surgery found that asymmetric foot temperature was associated with ipsilateral, same side, PAD on duplex ultrasound with significant diagnostic accuracy, making it a reliable clinical screening sign. Place the back of your hand on both feet simultaneously right now. One distinctly cooler than the other, particularly the toes and forefoot, is a finding worth documenting and reporting. Take note of which foot, how consistently it occurs, and whether it changes with position or activity. Sign number 4, the color conversation, pallor on elevation, rubor on dependency. This sign requires a simple positional test. Lie on your back and raise both legs to 45 degrees for 60 seconds. In a healthy leg with normal arterial supply, the color is maintained or minimally changes. In a leg with significantly reduced arterial flow, gravity-dependent blood drains downward and the leg blanches, turns pale or white within seconds. Now sit up and let both legs hang dependent. In a healthy leg, color returns normally. In an ischemic leg, a deep red, almost purple red, dependent rubor develops as the maximally dilated vessels of the oxygen-starved tissue fill with blood. Pallor on elevation followed by dependent rubor is called the Buerger sign. It is a physical examination finding that vascular surgeons use to assess the severity of arterial insufficiency. Positive Buerger sign correlates with significantly reduced arterial pressure in the affected leg. A study from the Annals of Vascular Surgery found that positive Buerger sign was associated with severe peripheral arterial disease on arteriography and with significantly elevated rates of concurrent coronary artery disease. Try this test with your legs. Note what you observe. If you see significant pallor on elevation or marked rubor on dependency, this is a finding to demonstrate directly to your physician, not in words. Show them the test result. Sign number 5, the nail narrative vestibular. Thick, slow-growing, dystrophic toenails. Toenail changes in the context of peripheral vascular disease are not primarily a fungal problem, though fungal infection is more common in ischemic tissue. They are a reflection of the nail matrix's dependence on adequate blood supply for normal keratinization and growth. Chronically ischemic toes produce nails that grow slowly, thicken abnormally, develop ridging and discoloration, and become brittle and dystrophic. The nail matrix, the growing zone at the base of the nail, requires consistent arterial perfusion to function normally. When perfusion is chronically reduced, nail architecture deteriorates. A study from dermatologic surgery found that nail dystrophy of the toes correlated significantly with reduced peripheral arterial flow on Doppler assessment, independent of fungal infection, making it a useful clinical marker when evaluated alongside other vascular signs. If your toenails have changed over recent years, thickening, slowing in growth, becoming ridged or discolored despite antifungal treatment. Add this observation to the constellation of signs you bring to your physician's attention. Sign number 6, the wound warning, sores or ulcers on the feet that won't heal. This sign requires urgent attention, not a scheduled appointment. A call today. Arterial ulcers, wounds on the feet or lower legs that fail to heal over 2 to 4 weeks, represent the most severe end of peripheral arterial insufficiency. They occur when tissue ischemia is so advanced that even minor trauma, a shoe rubbing, a small cut, a pressure point, cannot heal because the arterial supply is insufficient to sustain the wound healing process. Arterial ulcers are characteristically located on the toes, the heel, or pressure points of the foot. They tend to be punched out in appearance, with pale or grey wound beds, minimal granulation tissue, and disproportionate pain relative to their size, because the surrounding tissue is ischemic and hypersensitive. A study published in Circulation found that adults presenting with arterial foot ulcers had a 1-year mortality rate approaching 25%, driven primarily by the severity of the concurrent coronary artery disease, and a major amputation rate of 10 to 20% within 1 year without revascularization. If you have a wound on your foot that has not healed in 2 weeks, with no prior diagnosis explaining it, seek medical evaluation this week. Do not apply more bandages and wait. This is a vascular emergency in progress. Sign number 7, the swelling story, unilateral leg swelling, and a deep vein thrombosis risk. Not all leg swelling is cardiac, but leg swelling, particularly unilateral swelling of one leg, carries a specific cardiovascular warning that is urgent and time-sensitive. Deep vein thrombosis, DVT, occurs when a blood clot forms in the deep veins of the leg. The clot can detach and travel to the lungs as a pulmonary embolism, a potentially fatal obstruction of the pulmonary arterial circulation. DVT and pulmonary embolism together constitute venous thromboembolism, one of the most common preventable causes of cardiovascular death. Unilateral leg swelling, one leg distinctly swollen compared to the other, particularly with warmth, redness, and deep calf tenderness, is the classic presentation of DVT. It is a medical emergency. The appropriate response is emergency evaluation, not watchful waiting. A study from Stanford University found that untreated proximal DVT, clots in the thigh veins, was associated with a 30% risk of pulmonary embolism within 3 months, with 10% of pulmonary emboli proving immediately fatal. Bilateral leg swelling, both legs symmetrically swollen, is a different and equally important sign. It suggests systemic fluid retention, which in adults over 60 most commonly reflects congestive heart failure. The heart's reduced capacity to pump blood forward, causing fluid to back up into the peripheral tissues. Any new leg swelling, unilateral or bilateral, warrants same-day or next-day medical evaluation. Do not wait. Sign number 8. The vein visibility, prominent, twisted or bulging varicose veins. Varicose veins are not merely a cosmetic concern. In the context of cardiovascular health, they signal dysfunction of the venous valve system of the legs, the one-way valves that prevent blood from pooling in the lower extremities when standing. When venous valves fail, blood pools in the superficial veins of the leg. The increased pressure causes the veins to dilate, elongate, and become tortuous, the characteristic rope-like bulging appearance visible under the skin. This venous hypertension damages the surrounding tissue over time, contributing to leg ulceration, skin pigmentation changes, and chronic inflammatory changes in the leg. While varicose veins are primarily a venous rather than arterial condition, They share several cardiovascular risk factors: chronic inflammation, endothelial dysfunction, and sedentary lifestyle, with arterial disease. And venous insufficiency significantly increases DVT risk in affected legs. Sign number 9. The numbness narrative, persistent tingling or numbness in the feet. Persistent numbness and tingling in the feet, peripheral neuropathy, has multiple causes, and not all of them are cardiovascular. But in the context of adults over 60, the two most common causes are both cardiovascular risk factors themselves: diabetic neuropathy and ischemic neuropathy from peripheral arterial disease. In diabetic neuropathy, chronically elevated blood glucose damages the small nerve fibers of the feet, producing the characteristic glove and stocking distribution of numbness and tingling that starts at the toes and progresses upward. This neuropathy is a direct marker of diabetic microvascular disease, the same process damaging the small vessels of the heart and kidneys simultaneously. In ischemic neuropathy from PAD, reduced arterial supply to the peripheral nerves themselves, the vasa nervorum, the small vessels feeding the nerves, causes nerve fiber dysfunction. The numbness in this case co-localizes with other ischemic signs: pallor, hair loss, cold temperature in the same foot or lower leg. Sign number 10. The rest pain reality, burning or aching feet and legs at night. Pain in the feet and legs at rest, particularly at night, often relieved by hanging the legs over the side of the bed or standing briefly, is called rest pain in vascular medicine. It represents critical limb ischemia, the most severe stage of peripheral arterial disease before tissue loss begins. The mechanism. During the day, gravity assists arterial blood flow to the feet. At night, lying flat eliminates this gravitational assist. The already compromised arterial supply, now without gravity's help, is insufficient to meet even the resting metabolic needs of the distal tissue. The ischemic tissue sends pain signals. The patient hangs their leg over the bed, restoring gravitational assist, and gains temporary relief. This pattern, rest pain relieved by dependency, is a vascular emergency sign. It indicates critical limb ischemia with imminent risk of tissue death and requires urgent vascular surgical evaluation. A study from the Journal of Vascular Surgery found that critical limb ischemia without revascularization was associated with a 30% major amputation rate at 1 year and a 25% mortality rate at 1 year, driven primarily by concurrent cardiovascular disease. If you are waking at night with burning, aching foot pain that improves when you hang your leg over the bed, call your physician tomorrow morning. Do not wait for a scheduled appointment. Sign number 11. The color crisis, blue or purple discoloration of the toes. Cyanosis cavebien, blue or purple discoloration of the toes, or the specific pattern called livido reticularis, a mottled net-like purplish discoloration of the skin, represents impaired peripheral oxygenation or microvascular obstruction. Blue-purple toes that appear suddenly, particularly in one or two specific toes rather than all of them, may represent cholesterol crystal embolization, fragments of atherosclerotic plaque that have broken off from a more proximal artery and lodged in the small digital arteries. This is called blue toe syndrome. It is not primarily a toe problem. It is a systemic atheroembolism problem, a signal that unstable plaque exists somewhere in the aorta or iliac arteries, shedding emboli that are reaching the toes today and may reach the coronary or cerebral circulation tomorrow. A study published in Circulation found that blue toe syndrome, cholesterol crystal embolization to the digits, was associated with a significantly elevated rate of concurrent, severe aortoiliac atherosclerotic disease and carried a 1-year cardiovascular mortality rate approaching 30%. Blue or purple toes that appear suddenly, not from cold exposure, not from tight shoes, are a vascular emergency. Seek same-day evaluation. Sign number 12. The walking decline, reduced walking distance over months. The final sign is behavioral rather than physical, and it is the most commonly missed because it does not look like a medical symptom. It looks like aging, a gradual progressive reduction in the comfortable walking distance over months, not explained by joint pain, not explained by shortness of breath, is often the earliest functional expression of peripheral arterial disease before claudication pain is explicitly recognized. Patients reduce their walking distance in advance of the pain threshold, unconsciously self-limiting activity to stay below the ischemic threshold of their leg muscles. They stop walking to the mailbox. They take the closer parking spot. They choose not to join the family walk. They explain it as just not feeling as energetic. Meanwhile, the reduced physical activity that results from this unconscious avoidance accelerates cardiovascular deconditioning, increases cardiovascular risk, and reduces the collateral circulation that partially compensates for the arterial obstruction. A study from the American Journal of Cardiology found that reduced walking capacity, measured objectively by 6-minute walk test, was one of the strongest independent predictors of adverse cardiovascular events in adults over 60, outperforming several traditional risk factors in predictive power for major events over 3-year follow-up. If your walking range has quietly decreased over the past year without clear explanation, this observation belongs at your next medical appointment as an explicit clinical complaint, not as a side note. I want to close with something that I want you to remember long after this video ends. Your heart did not begin its trouble in your chest. It announced itself quietly, patiently, through 12 specific signs in your legs and feet, long before the dramatic events that fill emergency rooms and change families. The 12 signs in this video are the language your cardiovascular system speaks before it runs out of words. Learning that language does not require a medical degree. It requires attention. The kind of attention that comes from knowing what to look for and understanding what it means. Look at your legs tonight. Look at your feet. Run the Bjerger test. Feel the temperature. Check your toenails. Note your walking range. And if you see something that matches what I've described today, make the call. The best cardiovascular outcome is the one that begins with a conversation before the emergency. You now have the information to start that conversation. If this video gave you something valuable, a sign you recognized, a test you're going to request, a conversation you're going to have with a family member, please consider subscribing. Every week I bring you this same quality of honest, clinical, evidence-based information with nothing to sell and everything to give. Next week I'm going to cover the 5 foods that decades of cardiovascular research shows are the most powerful dietary interventions for arterial health, including one that reduces LDL oxidation by a documented 40% and costs almost nothing to add to your daily routine. The science behind it is some of the most compelling in nutritional cardiology. You will want to see that one. Until then, look at your legs, listen to what they're saying, and act on what you hear. Your heart is counting on you to pay attention.